Welcome everybody. We are coming to our meeting today, and we will have 3 lectures. And we have a new speakers and a new moderator with us, Professor Muhammad Al-Tahan. And Professor Muhammad Al-Tahan will lead the meeting today. Just I will summarize again. He is Professor of Cardiothoracic and Vascular Anesthesia and Surgical ICU in Mansoura University, and Associate Professor in Imam Abdurrahman Faisal ibn Abdurrahman, Imam Abdurrahman bin Faisal University in Dammam in Saudi Arabia, and he is the educational committee chair on the European Cardiothoracic Society, and also he published more than 50 articles in well-known journals, and he wrote 7 chapters in the anesthesia, and all his focus in the cardiothoracic anesthesia and the vascular anesthesia as well. Professor Tahan will lead the meeting today, and I will let him to start to introduce our speaker. Welcome, Professor Tahan.
Thanks so much, Dr. Yasser, for this nice introduction. First of all, I want to thank everyone for organizing this interesting and great initiative for a MEGA online course. And I want to introduce special thanks, greetings, and salute for all frontline defenders and martyrs from medical staff, particularly from anesthesiologists in Egypt and everywhere in the world. This MEGA online course, this is episode 20. There is a special thanks to Dr. Saad Mahdi, consultant anesthetist in Midwestern Regional Hospital, Merck in Ireland. He's the founder of this MEGA online course in anesthesiology and critical care, which is offered for our young Egyptian and worldwide colleagues. And he's working so hard to conduct this series. The learning objective of this evening for this webinar, by the end of this night, you will be being able to better understand the principles and management of coagulopathy in critically ill patients, the basics, causes, diagnosis, and management of perioperative electrolyte imbalances, and tips on the management of perioperative hypertension. Just a little housekeeping before we get started. If you have any question during the presentation, please type them into the chat box and we'll bring them up at the end of the 3 presentations. We will collect all questions and answers at the end of the whole session. We have about 20 minutes for answering of questions received from the audience. And unaddressed questions will be answered and posted on the Egyptian Fellowship Facebook group and website for a MEGA online course. Without further ado, I am delighted to introduce the first eminent speaker, Professor Samir El Ansary, Professor of Critical Care Medicine at Ain Shams University in Cairo. And he will talk about a very hot topic nowadays. As you know, in the era of COVID pandemic, we have many concerns about coagulopathy in these patients. He will talk about coagulopathy in general in intensive care units. Can you start, please, Professor Samir?
For this nice introduction. I am going to speak about coagulopathy in ICU. Good evening first, our colleagues and good evening our attendees. A great pleasure for me really to attend this course. If we speak about coagulopathy in the ICU, it is one of the main problems which we face in our ICU. We will speak about general problems which will face us related to hemostasis problems. I just first want to just summarize you about the coagulation pathway. As we see, very rapid. The factor 10 will be activated by either the extrinsic factor through factor 7, or through the intrinsic factor through factor 11 and 9 and factor in presence of calcium phospholipid and factor 8, it will change it to active factor 10, which in presence of calcium and the phospholipid and factor 8 will change factor 2 or thrombin to active thrombin. And then thrombin will act on the fibrinogen and change it to fibrin, and through factor 13 it will be stabilized as a clot and becoming more firm. And after that, the fibrinolytic system, as you know, will start to act and start destruction of this fibrin. As we know, warfarin will work here at factor 7. It will stop or interfere with the action of all or secretion of all factors 2, 7, and 2, 5, and 7, and 10. Also, rivaroxaban will affect one of the DOAC, which act on factor 10. Dabigatran also act on thrombin or on factor 2. We have to be oriented with any problem in the patient from the point of bleeding or so on. We have to make some lab result, a lab investigation as platelet count to see if this platelets, if the patient complaining of thrombocytopenia or thromboasthenia. Peripheral smear to check for any schistocytes or hemolytic problems, and bleeding time also will guide me. BT will inform me about the extrinsic or about the vitamin K dependent factors and the coagulation factor. BTT will inform me also about the activated partial thromboplastin time, will give me idea about the factors 11, factor 12, factor 9, factor 8, von Willebrand factor, and also through mixing tests which will improve the clotting state in the sample if there is deficit in the factors. If not improved through mixing tests, this meaning there are antibodies to these factors. The dimer also will give me idea about the fibrinolytic state. If the patient exhibiting more fibrinolysis as liver cirrhosis and so on, some patients with high fibrinolysis, or FDP, which is the end product of fibrinogen, and the rest to CT test also for von Willebrand factor and see if the patient suffering from von Willebrand factors or not. Also, there are another test which is dilute leucine fiber venom time, DRVVT, to predict any antiphospholipid in patient exhibiting hypercoagulability. Don't correct always. Today, really, I am going to stress on some points of coagulopathy, not speaking about in details about coagulopathy. Don't correct coagulopathy in critical ill patient unless there is a specific reasons. There is bleeding or a patient going to invasive procedure and so on. Massive transfusion of blood products can cause harm, and we know, all of us know TRALI and the complications of massive blood transfusions, which lead to RDS in some patients. And so we avoid now to push too much blood transfusion or component of blood to the patient. How much fresh frozen plasma should be transfused for each unit of backed RBCs? Really, there are many suggestions as 1 to 1 or 1 to 2. No difference actually from the point of mortality or morbidity along the critical ill patient. High fresh frozen plasma strategy for non-massive transfusions, less than 1 unit packed RBCs per 24 hours, had 12 times incidence, and so lead to TRALI or RDS due to lung injury. Really, European now not use fresh frozen plasma at all, preferring thromboelastometry to guide for factor concentrate infusion, like prothrombin complex and factor 8 and fibrinogen. And they depend on the individual factors. For the deficit factors, they give the deficit factor, not fresh frozen plasma as a whole. These principles apply to patients with trauma. Applying them to massive also gastrointestinal bleeding may be under investigation and mostly agree. For hemostasis monitoring with thromboelastogram or thromboelastography, depend on a series of processes which take place. No, it is not a one process. It starts first by initiation of the coagulation, as we know, and platelet plug formed, and the fibrin strands start to lay down on it. After that, the clot grows through clotting factors and the coagulation factor till it reaches the maximum clot formation, and then starts to degrade or to fibrinolysis. And so if we can detect any stage of this, any defect or default in any stage of this process, we can correct it by the individual which is deficit. Like here, BT, INR, and BTT predict the coagulation factor or inform me about its platelet count here will strengthen this stage. And so we depend on TEG, which is available as ROTAM or TEG, the same principles. Just we put a sample of blood here, and this pen rotated as the rotation here may be from the cuvette itself or from the pen or from the pen to just simulate an venous blood flow and start coagulation. And as the blood in this cuvette started to clot or started to coagulate, it will activate this pen and make it rotate more rapidly, and will draw a figure like this on the graph. And from its presentation and its interpretation, I can detect which is defect in the process of coagulation. As we see here, this is the R stage or R, which is the reaction time. It takes about 3 to 9 minutes. If it is prolonged, there is meaning there is defect in the coagulation factors. And after that, the K value or the which start from the end of R till the clot reaches a firmness, reaches the height of about 20 mil, and it gives me impression about the firmness of the or stability of the clot. If it is normally it is about from 1 to 3 minutes to reach this value. After that, the alpha angle here. Alpha angle informs me also about the normal process of coagulations and fibrinogen content. The maximum amplitude here also informs me about the total clot strands, normal value from 50 to 78. After that, it started the lysis after 30 minutes. And if after 30 minutes, the lysis exceeding 9%, I say there is more fibrinolytic effect or more fibrinolytic activity. And so I have to treat with epsilon aminocaproic or antifibrinolytic agents. We can see figures here. This is a normal one, as we see, normal R value and the normal K value, and the alpha angle is optimum. In this one, there is anticoagulant and factor deficiency. We see R is prolonged and the K wave and the key interval is here. And you can correct this one by cryoprecipitate and platelets. And the stop, of course, is the anticoagulant. Here is a platelet alpha angle. After that, here we can see fibrinolysis. We can see after 30 minutes, the fibrinolytic activity is more than 9%. And so this patient need antifibrinolytic. This one has a hypercoagulable state. As we see, the alpha angle is increased. Alpha angle is increased, and the magnitude also, the maximum amplitude is increased. This is a picture of DIC at start in the first stage or early stages. There are hypercoagulability, as we see, increased alpha angle, and the R wave and the R time is reduced, and the maximum amplitude is increased. And after that, starting the coagulability to decrease, hypocoagulability, and R prolonged, and the key also prolonged, and alpha angle decreased here and the maximum amplitude is decreased. And so from the interpretation of the thermoelastogram, I can predict which which ingredient or which factor is decreased or deficit, and I can manage. This is clarifying the normal value. Our time starts our time about 5 to 10 minutes. If prolonged, we have to give fresh frozen. Key time 1 to 3 minutes. If prolonged, we can give fibrinogen or cryoprecipitate. Alpha angle, if it is normally from 50 to 70, and if decreased less than this, we can give cryoprecipitate, which contain fibrinogen. Maximum amplitude from 50 to 70, and if it is low, this maximum amplitude, we can give platelets or desmopressin, either nasal or IV. If lysis after 30 minutes more than 9% or 8%, this meaning excess fibrinolysis, and we have to give tranexamic acid or epsilon amino caproic acid. This is also repeating what we say. How should tranexamic acid be used in massive transfusion? It must be given within 3 hours after injury. But I wanted to say something. Don't give tranexamic acid if the patient exhibiting low fibrinolytic activity, because it may cause some thrombotic events. It may cause cardiac ischemia, may cause cerebral stroke, and so on. And so it is till now under investigation. Yes, it is approved. It improved the morbidity and so on, but we recorded some side effect from its routine use of tranexamic acid in patient not exhibiting high fibrinolytic activity. Tranexamic acid may be used also in other situations in which they exhibiting some bleeding tendency, especially during OR or during gastrointestinal hemorrhage, and also under more investigation to be proved its efficacy. Fibrinogen in a massive transfusion, if less than 150 to 200 grams per liter, we have to transfuse fibrinogen to the patient, and it is really an expert opinion. Correcting coagulopathy before invasive procedures and surgery, no good evidence exists. And the routine using fresh frozen and before invasive without the patient exhibiting any bleeding, I think not supported. And to support the practice of transfusing fresh frozen plasma to correct lab abnormality in coagulation parameters prior to invasive procedure or surgery, it is not proof efficient thing. INR of 1.5 or less, we can insert central venous line. We can insert even central venous line in a patient with INR with less than 2.5. But arterial line, we can't. We have to improve, or we have to transfuse first fresh frozen or prothrombin complex concentrate. Expert endorse giving vitamin K 1 milligram orally daily or 10 milligram IV weekly to ICU patient at risk for bleeding, because many critically ill patients are deficient in vitamin K in ICU. Disseminated intravascular coagulation or thrombohemorrhagic disorders, we sometimes face with these problems, and it differs, and its degree of intensity or severity differ from patient to patient, but we can be faced with this problem, especially in multi-organ failure and in severe sepsis and in some situations like placental abruptio and amniotic fluid embolism and so on. Disseminated intravascular coagulation in ICU, both pro and anticoagulation factors are consumed along with platelets. We find every lab investigation is started in DIC. BT is high, BTT is high. Lab coagulative index or lab. DIC most often results from sepsis, but widely variable in its severity and manifestations. From low grade coagulation or coagulating abnormalities to overwhelming organ failure as in meningococcal sepsis. Perfused hemorrhage management of DIC is guided by the local expert opinion. In patients who are bleeding, we can transfuse platelets up to 50,000, fresh frozen plasma to INR if less than to less than 1.5, also fibrinogen if it is less than 1.5 gram per deciliter. Also, heparin in some situations we have to give in DIC with thrombosis or peripherals, in amniotic fluid embolism or severe persistent DIC, or in promyelocytic leukemia. Fibrinolytic inhibitors we can give if the patient exhibiting high fibrinolysis. Thrombocytopenia in ICU, it occurs in 20 to 40% of medical and surgical patients in ICU, and its cause is usually impossible to identify. The important thing is to rule out heparin-induced thrombocytopenic purpura, the TTP. All the microangiopathic purpura is we have to exclude because it end organs, the limb or the patient as TTP, as HELP syndrome, as these causes and lead to multi-organ failure, and so we have to start plasmapheresis and fresh frozen transfusion as soon as possible in TTP. In HET, we have to stop all the anticoagulant heparin and low molecular weight heparin, and we can start alternative one as ergotamine. Because of this false positive of always we overdiagnose HET in ICU, and we have to depend on 4T test for predicting HET as early as possible, which depend on timing, either timing from 5 to 10, 15 days, it changes or any increase in platelets, and we have to depend on 4 or 5 HET will be proved to be present. Thrombotic cytopenic purpura, TTP, asks the lab and the nephrologist to look for fragmented red cells to sites in the smear, peripheral blood smear, and if you diagnose it, we have to fresh frozen plasma or plasmapheresis as soon as possible. In thrombotic thrombocytopenic purpura, diagnosis depends on thrombocytopenia, hemolytic anemia, and histiocytes in peripheral smear, fever, renal dysfunction, CNS dysfunction. But the coagulation factors, BT and the BTT, is normal. Slight headache or mild headache up to confusion, up to coma in some cases. Renal dysfunction also is present, but in some cases not present, may be more evident or more clarified in hemolytic uremic syndrome than in TTP. As we know, the pathophysiology or the underlying mechanism of TTP, either deficiency of Adams 13 or autoantibodies formed against Adams 13. And as we know, the rule of Adams 13, which broke down the von Willebrand factor, macromolecules of von Willebrand factor, and so prevent the macro aggregates of platelets inside the vessels. Its deficit will lead to thrombus formations all over the vasculatures and the multi-organ failure. TTP usually causes very low counts, less than 20,000, and doesn't typically elevate the prothrombin time, helping to distinguish it from the other coagulation factor or coagulation parameter. Recognition, very important in TTP, and we have to start plasmapheresis, which will improve the patient. Till the patient, plasmapheresis must be continued till the patient exhibiting normal platelet count. Immune thrombocytopenia may develop after viral infections and may be acute form or chronic form, and always immune thrombocytopenia diagnosed through exclusion of other causes of thrombocytopenia. If we make blood smear and see the RBC is normal, no histiocytes and normal white cells, and so we can diagnose ITP. Treatment of ITP, we can start corticosteroids, prednisone, 1 milligram per kg per oral once per day with a slow tapering at. We can start anti-CD20 as rituximab, 375 milligram per square meter IV once per week for 1 month. In refractory cases, of course, or we can use thrombobiotine-like agents such as L-thrombopage and romiplostim. L-thrombopage we use 25 to 75 milligram once per day, or romiplostim 1 to 10 microgram per kg once per week are indicated. Splenectomy in cases of sequestration, so on inside the spleen, as in cases of liver cirrhosis and the spleen. And if we make splenectomy for refractory cases, we have to vaccinate the patient against streptococcus pneumoniae, Haemophilus spleen. We can use all also intravenous immunoglobulin, a rapid effect, and in patient exhibiting severe patients who are actively bleeding, or in those who use intravenous immunoglobulin G, 1 gram per kilogram, once per nazole, dapsone, vincristine, mycophenolate. But the better is the best, and the early treatment or the first line treatment is steroids in such patients. In hemolytic uremic syndrome, the patients may be exposed to E. coli infection and the Shiga toxins intoxication, and so exhibiting hemolytic uremic syndrome, or may be dysregulated of the complement system in HEM, as especially complement C5, and in those patients we have to dialyze him. Patient will coming suffering from diarrhea, sometimes abdominal pain, nausea, vomiting, hypoglycemia, other manifestations, but the main manifestations is diarrhea, and also the really thrombocytopenic microangiopathy and schistocytes in blood smears also. But the renal function impairment is more dominant in this, or more high in this patient with hemolytic uremic syndrome than in those with TTP. Treatment, plasma exchange and dialysis, or we can use eculizumab, which is anti-complement 5, and we have to vaccinate the patient against meningococcal meningitis if we treat him with eculizumab or with anti-complement. Coagulopathy of trauma and massive transfusion, of course, we have to, is an important item we have to avoid. Hemodilution, hypothermia, all these items predispose to bleeding, more bleeding in trauma patients. In addition to tranexamic acid, as I said, if the patient exhibiting a high fibrinolytic trauma and massive transfusion, maintain perfusion and oxygen delivery, very important, of course, and oxygen delivery not depending only on transfusion, depending on cardiac output and cardiac contractility and so on. Drug volume and so on. Early tranexamic acid post-trauma within the first 3 hours is very important. Don't give after 3 hours. Low or dysfunctional platelet, transfuse platelet. If there is factor depletion, measure PT and BTT and fibrinogen, and you can transfuse fresh frozen cryoprecipitate if needed, and according to blood product ratio 1:1 or 1:2, as we said. And the better, of course, those patients exposed or subjected exactly which component they will need for correcting their coagulopathy. Blood product ratio, as we said, 1 or 1 to 2, and no difference in the mortality. Von Willebrand factor disease, we have 3 types of von Willebrand, type 1, 2, and 3, in which we see increased bleeding time, and the treatment here is desmopressin, which is synthetic from vasopressin, and we give 0.3 microgram per kg, either nasal spray or IV. If not responding, we can push factor 8 concentrate or cryovenous immunoglobulin in such situations. Hemophilia, of course, according to type, hemophilia type A or type B, we give the correct the factor levels. We can give factor 8 in hemophilia 8 and factor 9 in factor also, and factor active 7 or prothrombin complex or 9. As we know, prothrombin and 4, it contains the coagulation factors two, 7, and 10, in C and vitamin S and heparin and low prothrombin complex concentrate. Factor 7 really, when you give active factor 7 or reactivate factor 7, take care of thrombotic, so cardiac ischemia in many patients, especially in trauma patients. Related bleeding, we have to consider drug interactions, and we will find the increased PT and treatment here, fresh frozen and activated prothrombin complex concentrate. We can give vitamin K. Heparin, we can replace warfarin with heparin. Contains factor 8, factor 13, fibrinogen, von Willebrand factor, indications in cases of hypofibrinogenemia, if and obstetric hemorrhage. It does 8 to 10 units initially from cryoprecipitate. Bleeding with unfractionated heparin, as we know, the specific antagonist here, we have to stop heparin, of course, and we have to give protamine 1 milligram to every 100 units. Bleeding from low molecular weight also, we can use protamine. Yes, it is less effective, the dose, especially in obese patients and in renal impairment patients, and also with hepatic dysfunction. Bleeding with antiplatelets, we have to stop the antiplatelet clopidogrel and others about 5 to 7 days before operations. And if there is bleeding, we have to transfuse platelet. Bleeding from dibigatran or antithrombin or anti-factor 2, we can use either suzimab now. It is available, and as we know, dibigatran, we can dialyze it because it is a dialyzable one. If we have either suzimab, it is a specific. For rivaroxaban overdose or ipixaban, we can use in some hospitals 66% renal execution of rivaroxaban. But as you know, they are not dialyzable, and the specific antidote here and not using in such situations the prothrombin, even active factor 7, not active against rivaroxaban or ipixaban. Of course, dibigatran we can predict it through BTT. As we know, the dose of hydrosizumab is about 5 gram IV. It may be repeated. In trauma and the hemorrhagic shock, no rule for reactivated, I said reactivated factor 7, and may cause some thrombotic complications, and no rule also for BCC, prothrombin complex concentrate. And we have to use or depend on TEG and ROTAM as we clarified first for predicting the component deficit in such patient. Thrombocytopenia in patient in ICU, of course, there are many causes, and we have to exclude at first the medications such as heparin causing heart, alcohol, if this patient is using some drugs, if the patient has a history of autoimmune disease, a patient suffering from fever, headache, rheumatoid, abdominal pain, may complaining from TTP or HUS. Also in patient with liver disease because of thrombocytopenia, especially if spleen is enlarged, will cause sequestration of platelet infection and translocation and the deficit thrombopoietin, the hormone secreted for stimulating platelet photon to look for and exclude TTP, as I said, and the DIC and the microangiopathy they due to pseudo thrombocytopenia from the anticoagulant used, such as editor, use another anticoagulant. PT, BTT, fibrinogen, and the D-dimer in DIC will be increased. Renal function testing, very important to exclude HUS or PTB in cases of schistocytes in smear. Also look for the other causes such as thyroid function, hypothyroidism, hyperthyroidism, or viral infection, very common. Sometimes we diagnose hepatitis C from evaluating patient excepting thrombocytopenia in about 30% of patients with hepatitis C. If there is no cause for underlying cause, you have to suspect ITB or immunogenic thrombocytopenia and start steroids. COVID-19 patients, I mentioned here one important point. Most of the patients, or large percentage of those patients suffering from cytopenia, pneumonia in any patient with lung disease. Thrombocytopenia has been described in 58% of subjects with severe COVID-19 patients. At the same time, thrombocytopenia has been associated with an increased risk of mortality in these patients. I want to say something. Most of the patients of those of anticoagulant like Clexane and heparin, and to try to predict and titrate the anticoagulant dose which we know suffering from cytopenia. And I think the investigation or the research must concentrate also not on antiviral research for COVID-19. We have also concentrate on the optimum anticoagulant for COVID-19, which is coming to you except in thrombocytopenia, and you start and you may introduce them in. So concentrate on. We have to concentrate on this. Every hospital really or every medical center must put these targets for transfusion. A non-bleeding patient, and the store is 10,000 per transfusion of blood. If the patient bleeding, in neurosurgery, of course, and
Thanks so much for Professor Samir for this very informative and helpful.